The following images depict an abbreviated surgical technique for the Arthrex opening wedge osteotomy system designed in conjunction with Dr. Giancarlo Pudu of Rome, Italy, Dr. Peter Fowler, and Dr. Ned Amendola of London, Ontario, Canada. This system was developed for the treatment of pain and/or instability associated with lower extremity malalignment. For an in-depth description of the surgical technique, contact your Arthrex sales representative for a free video and written surgical protocol. The line of weight bearing, a line drawn from the femoral head to the center of the tibial talar joint in a normal patient, is depicted by this image. The line of weight bearing in this image is typical of a patient with a varus deformity. The correction needed is determined by using standing full-length radiographs. Allowance is made for magnification. First, a line is drawn from the femoral head to a point on the lateral aspect of the tibia that is 62% of the width of tibial plateau. A second line is drawn from that point to the center of the tibial talar joint. The angle created by the intersection of these two lines represents the angle of correction needed. Usually 1 degree of correction is made for every millimeter of opening of the osteotomy. Under fluoroscopic control, a 3 mm guide pin is inserted from medial to lateral into the tibia beginning 1 to 2 centimeters below the joint line at a point central in the AP plane and parallel to the tibial plateau. The pin is inserted to the lateral cortex. The osteotomy guide is assembled by first placing the parallel guide pin sleeve assembly onto the post of the osteotomy guide. The guide pin sleeves are then inserted through the holes of the parallel guide pin sleeve assembly. The angle of guide is set so that the pins enter the tibia and pass through a point cephalad to the superior aspect of the tibial tubercle. The osteotomy guide is then placed onto the 3 mm guide pin so that the rear of the guide is flush with the laser line etched on the guide pin. Alignment of the guide is such that placement of the two 2.4 mm guide pins will be parallel with the slope of the tibial plateau. The parallel guide sleeve assembly can be rotated to make changes to the slope of the tibial plateau if desired. Normally, the guide will be set to 0. The pin sleeves are positioned against the bone. The two 2.4 mm breakaway pins are drilled to a depth that intersects the plane of the 3 mm guide pin when viewed in the AP plane with fluoroscopy. The osteotomy is created along the plane established by these pins, and a 1 cm lateral cortical bone hinge is made when osteotomes are driven to the same depth as the pins. The cutting guide is positioned over the distal pins. The guide may be secured by placing a temporary pin into the tibia with a mallet. The breakaway pins may be shortened to facilitate access of the saw to the cutting guide. An oscillating saw positioned on the inferior surface of the cutting guide is used to resect the tibial cortex medially, anteriorly, and posteriorly. Osteotome blades, available in 10, 25, and 35 mm widths, are assembled on the handle as shown and are used to complete the osteotomy. The osteotomes have depth markings on the blades. Fluoroscopic conformation should be checked repeatedly throughout the cutting process. The cutting guide and guide pins are removed. The osteotomy wedge is assembled as shown. When the desired opening has been achieved, alignment is verified externally from the hip to the ankle, as well as by fluoroscopy, to ensure the weight-bearing line is through the lateral compartment. Adjustment to the opening may be accomplished by impacting or extracting the wedge to the next appropriate size. The handle is removed and the plate is placed between the tines of the osteotomy wedge. Optimal plate placement is anterior to the leading edge of the medial collateral ligament insertion. Spacing of the tines is designed to accommodate the width of the Pudu osteotomy plate. The plate is fixed with stainless steel 6.5 mm fully threaded cancellous screws proximally and 4.5 mm cortical screws distally. Tricortical wedges of autologous bone harvested from the iliac crest are used as grafts in the ostomies greater than 7.5 millimeters. Following plate fixation and bone graft placement, the wound is irrigated and closed over a drain in the routine fashion. A sterile dressing is applied and the knee is placed in a post-op hinged brace. The patient can begin non-weight-bearing ambulation on crutches on the second post-operative day. Healing progression is determined by progressive X-ray follow-up. Arthrex has technically trained representatives to assist orthopedic surgeons in implementing new techniques and associated products. Please contact your local representative or Arthrex directly for additional information.